Everyone. I don't think anybody's muted. Can we hear anybody? Oh, everyone is muted. Sorry about that. Thank you for joining us today with our fall prevention community of practice. Today will be a very important call with Sarah Pavelka. I'm very excited to have her present some things. She has some information that will really help you with your fall's community of practice. If you weren't on the What's Up call this morning, I just wanted to reiterate that we have some celebrating to do, and I think that this is due to our falls prevention community of practice. When we look at the measure total falls, our baseline period was January 2012 to December 2012. Our baseline rate was 3.79. I know that in HEN 1.0 we did not budge this much, but our last snapshot, which was December through February 2016, our rate did decrease to 3.17. This is a 16% reduction. Knowing that this fall's community practice goal was a reduction in 10% by August, we have not only met our goal, but surpassed it. So thank you to all that are consistently on this call, either giving information, receiving information, but obviously implementing great changes. So without further ado, I would like to introduce Sarah Pavelka. All of you guys love her, know her. Every time that she speaks, this is a comment that I hear. Can she talk all day? Can she talk longer? I love Sarah. So we will open the line at the end, and I know you're all smiling at that because some of you that I'm looking at, I've heard it right out of your mouth. So here we go. We'll let Sarah take over today.
All right. Thank you, everybody. I am in Jennifer's office here in Des Moines, and it's raining, so I'm assuming it's pouring where you're at. I drove through some rain this morning today, so if you happen to get kicked off, just come back in, call back in. We do have everybody muted, but I will take a couple opportunities to take everybody off mute, and so we have a chance to chat. I have prepared some slides, but I want to take the time for you guys to talk a little bit about what's working and what's not working. And I know Jennifer's got some ideas. She went to a seminar presentation on fall symposium. There you go, fall symposium in the last couple weeks, and got some really good ideas. So we stole some of those ideas out of that, and we are going to take an opportunity to just kind of bring in some information that she learned at that symposium. So I will go ahead and get started, but before I do, I'm gonna unmute you guys, and can I have somebody just jump on and let them? We're gonna do a sound check. How's the sound?
It's good over here.
It's good over here. Okay, so somebody did it. So I'm gonna take you guys back and mute you all, and we'll have an opportunity to, there are 19 individuals on, so excited to see everybody's name out there, and we'll, again, unmute you as we go. So let's talk a little bit about falls, and what I'm going to talk about today are a couple different things, but really focus on root cause analysis. So when we talk about the agenda and things that I'm going to cover, we're going to talk a little bit about root cause analysis, but I'm also going to bring in the culture of change and what it takes, because I do think this is a movement that we need to be able to move across our organizations. And then I will touch on a little bit of area, and Jen's going to jump in and talk about maybe some fall assessments and what we can do. Some fall huddles. I know many of you are having fall huddles, so maybe a way to keep them fresh and keep them exciting so people feel that they are an important piece of this. And then last but not least, we're going to talk a little bit about the rehab professionals or physical, occupational, and speech therapies for fall prevention. And as you guys know me, this is from the bottom of my heart, you know, starting in that as an occupational therapist, we were a really critical piece of that fall prevention and what patients did in the hospital, outside the hospital, in their home, in the nursing home, and so continuing to stretch our boundaries of the care across the continuum. So bringing a little bit of those influences in as well. So let's talk a little bit about falls. What first I'd like to do, though, and I'm hoping I can do this in, whoops, no I can't. Get it out on YouTube. So I'm going to do a little exchange here, you guys. Hold on, because you have to watch this video. As you guys all know me, I'm going to copy this. Hold on. My links aren't working. Can you get to YouTube here, Jen? Sure. Okay. Okay, you can go ahead. All right. If you guys want, this is out on YouTube, and you can take an opportunity to be able to look at the video. I gotta skip the ad. So how many of you guys feel like this is potentially your organization? My favorite. Oh my gosh. So just to add a little funnies, if you guys want to talk a little bit about potentially your falls, you can use that video. I just typed in falls animals, because you always gotta talk a little bit of, have a little funny in there, and be able to talk as we move forward to be able to lighten this up. This is a serious issue. We do have complications that come from the falls, and many times our teams do take it very, very seriously. But just to give you guys kind of the funny side of things today, as we know, because sometimes it does take a little humor to break us up with the seriousness. But so let's talk about how we can prevent a fall. We know that one of the best things that we can do prior to and after a fall is to conduct a root cause analysis. I will give you guys a little sneak peek. Some of you know I've been working on my dissertation, and the work that I have been looking at is taking the measures across Iowa, including falls, and looking at what were the predictive things that we were doing in organizations to actually have an impact on clinical outcomes, and falls are one of those areas. The one thing that consistently keeps coming up in my research is to say if we do or if we have done a root cause analysis, it will impact the number of occurrences that we have with clinical quality outcomes, particularly falls, particularly having VTE. I know we're not going to talk about VTE occurrences, but using those root cause analysis tools does have a significant relationship on preventing the occurrence. And to be honest with you, they were looking at lots of behaviors in my dissertation. Root cause analysis is the only one that's consistently makes an impact. There's lots of others, dashboards and communication and leadership, and root cause is the one that continually keeps coming up. So I'm a strong believer in this, and many of you know that even from the work that we've done in the past with lean and other things, we do have some analysis to show that root cause is important to our PDSA or to our lean events. There's lots and lots of root cause tools that you can use, fish bones, run and control charts, histograms, and so on, and so you guys can read through these. I think probably the 5 whys is one that we all try to use the most, and we're going to talk about the 5 whys a little bit later on and talk about how you can kind of improve your use of the 5 whys. And so we'll talk about that one specifically. But I know there's lots of other root cause analysis tools that are out there, but here's a list of a few of them that you can be using. They all have great intentions. They're all used a little bit differently, but I will tell you that all of these root cause analysis tools are retrospective, meaning you use them after the event has occurred. You study your work and you study what's been done, and you hope to actually prevent it in the future, but these are all retrospective. So even with the positive impact that we have with root cause analysis tools, don't think that this is going to solve everything, because you're looking at an event after it's already been done. So hoping that you can prevent the next patient, the next person. But again, we have to have an event to do a root cause, which in one hand is kind of counterintuitive. We don't necessarily, if you think of that, you got to have something bad so you can study it to prevent the next one from happening. So that it cannot be the only defense that you have with your falls and your fall prevention. So moving on, so here is a little bit, I told you we were going to kind of dive into the 5 whys. Why would we want to use the 5 whys? Well, again, probably looking at the attendee list, you guys are more than familiar with these, and using the 5 whys. Here's some reasons. This is not necessarily just for you, but if your nursing managers or your managers or even your team leads, your supervisors saying, I don't understand that this tool is, why are we having to do this? I know why it happened. Well, let's continue to drill into the situation and discover really what can be sustainable. The difference between using the 1 why, asking yourself why did it happen and stopping there, and drilling into those 5, at least 5 layers, if you can, is often when we do the first one, we think we have an answer. All sounds great. Everybody's like, oh yeah, that's it. But it's not enough. We need to drill in there, because if you stop at that 1, it's not sustainable. It tends to not be what's really causing the situation, and then it's difficult to sustain it. If you stop at the 1, it's kind of that shotgun approach where you're going to say, okay, we think this is it, and we continue to move on and move forward. So it does take time, and it does take some opportunity to drill into the 5 whys. And I like this example. I pulled this off the internet. If you start with, there's not enough nails, so we lost the shoe on the horse. We have 1 less horse, which means we have 1 less warrior, so it means we could potentially lose the battle and therefore lose the kingdom. I like this analogy because I do think often falls, we need to win the battle. We need to continue to win over our kingdom of having patient safety. And if you think about it, that you have to get all the way down into, well, why didn't we have enough supplies on the floor, or why didn't we have enough resources that the staff needed to be able to win the war and not lose those battles. I liked this analogy, or this little image that's there on the slides, because I do think falls are a battle, and it's about protecting our kingdom. So moving into those 5 whys. One of the reasons, and I will be honest with you, when I first started doing the 5 whys, it is a difficult, seems easy, ask why 5 times, And yeah, you're going to be able to wipe away the layers. It all sounds great. It all is wonderful. But it's tough. It's really, really difficult to do that. And sometimes I don't want to say it's almost intimidating, but it's almost scary for you as a facilitator or quality professional to go out there and ask individuals why. So what I'm going to present to you is kind of a different version of it and be able to talk about some reasons why this may not be working as easily as we could. So one of the first things, all information is great. We have good data, but sometimes we have to think about that when we have good data, we don't necessarily, if we get good data in, we don't necessarily get as great data out. So we need to be careful about what comes in and how we're presenting it out. So assessments are important, and we'll talk about later on to do that. I do hear consistently that time and the time to focus on this after the event. So after a fall occurred, it's hard. Staff they have other patients. Managers may not be there on the floor to even get it reported, or, oh yeah, it happened a few hours ago, or happened earlier in the day. We need to focus on having these assessments and root cause analysis done in a timely, effective, and supportive manner. So I know we can't make the day stop, but how can we make it stop as much as possible? And we've got some hints on that. Obviously, you guys are involving the people that are involved in the work and the tools to discover the root cause. So getting in there and using the people that are doing the work and the tools that are available for prevention. So being able to gather the team and not sit in the boardroom, but stand right out there in the areas where it's happening and go look and see what's going on. Some people are not necessarily understanding the purpose of a root cause analysis. So we get, we get intent with our work, and they say, oh yeah, we'll do it later, or we'll do it when we can, or they're again intimidated by using tools such as maybe a fishbone or 5 whys, or even how to do a Pareto, and so we avoid if we're not comfortable, and then it doesn't get completed, or it doesn't get completed with good effects or efficacy. I can't say the word today. It's too early. Thank you. So it just doesn't work for us. It doesn't come out to be the way we wanted it. And then last but not least, using the tools, I think, again, we try to maybe not necessarily intently skip through root cause analysis, but we really, we study the current state and we say, oh yeah, we think this is what can fix it. And so we jump all the way to that solution, the problem solving. We're in healthcare, remember, you guys have all heard me before, we're really good at problem solving because that's what we're trained to do, is solve problems. But we're not very good at looking at that underlying diagnosis, so using those tools. These are just a few things that came up off my head, why this is all, it sounds great, sounds ideal, but there's lots of other reasons why all of this isn't necessarily going as planned. So just as we kind of think about it, again, it all sounds ideal in a perfect setting. So let's talk about what we can do to move through some of this and what we can do to actually create a good environment and move forward. So kind of your takeaways from today. The first thing I want to talk about is we need to start from the beginning. We need to start from before the patient even thinks about coming into your organization. We need to change the process once those patients are within our organization or within our walls. And as I look through the list, I think most of you are probably from a hospital facility, but some of you also have long-term cares associated with your organization and even home health agencies. We need to change the processes within all of those organizations. So within your 4 walls, whatever you call it. And these we will gain in the end. So let's start from the beginning. I will be honest, I'm not a nurse. I'm not saying I have done a nursing assessment, but I have done an OT assessment. I've done lots of them, done plenty of them. And this was my point from earlier. If we get good data in, we can get good data out. We really need to stress that those people who are doing those patient assessments, whether it's care team coordinators, nurses on the floor, physicians, emergency room, staff, we need to be able to have a clear and clean assessment of those patients. Are we doing the run-of-the-mill assessment for every single patient? Does it all look alike, sound alike, and we really don't get any detailed information on the patient? So it's great to say we have standard work, and I'm not saying that trust me when I say we don't bend our standard work, but we really listen to the patient and say, what are they saying? Do they have somebody at home with them? Are they an energetic individual and want to be at home and or even out in the facility, but yet we're asking them to cut back on those activities that really made their kind of their life whole. And so we need to be able to listen to that, and we need to be able to customize not only our assessments but our care related to that. And I think you guys know that, and but sometimes we just need to we know it, but we need to remind our staff to listen for those little hints and those little things that you'll pick up in those assessments. And again, we all need to include the family or any caregivers. So maybe it's not just a few-minute assessment when they come in, but can you, get somebody on the phone? Can you talk to them about what's going on? What's their life like at home, or what have they been doing at home? What are their desires and what are their goals when they continue to get home or continue to be discharged? Where do they want to go? I also want to talk about that we need to think about what was considered normal for this patient. So is it a meal? Is it a routine? Bathrooms? What's their house look like? Where's their washer and dryer? And I know a lot of these questions seem things like your rehab professionals would ask and get answers for, and my answer is yes. So as the nurses are feeling like, man, I just don't have time to do that, it's important to, again, involve that care team to be able to see this patient kind of from a holistic, patient-centered view. One of the things that we all know is that when a patient comes into our facilities, they must change and adapt to our rules. Breakfast is served at 8 o'clock. Meds are given at 9. Bathrooms, you can go to the bathroom when the nurses do the rounds. Your toilet is now 20 feet away from your bed. All those things could be different from what they had in their prior living situation. So all of a sudden, we're asking them to have, for a very short period of time at least, a new normal. Well, and we know that. How many of us, even, able-bodied, healthy individuals, if you go to a hotel, how many of you feel like you're all of a sudden doing exactly the same routine and nice and smooth morning routine when you're at a hotel? It's fun. It's great to be away from home, but it's different, and things are disjointed. And so why would we expect a patient to all of a sudden be able to do things as normal when they're all of a sudden in the hospital? And so we need to think about this. So, for example, if their normal routine is to get up and to get ready and breakfast by 6 or 6:30, and we're asking them to wait to 8 o'clock to breakfast, what does that do to their energy level, their endurance, their stamina, all those things? They're 2 hours behind on food. I know what I'm like when I'm 2 hours behind on food. Not only am I not happy, but I don't feel real well. And so we need to think about, what does that do? So all of a sudden we get somebody up 2 hours behind on food and ask them to sit in a chair when their meals come. Are they going to have the energy, the strength, the endurance, all of those things to do it? So as we bring that individual into our world and we're asking them to change and adapt to our world, basically within a few minutes, we have to be able to say, what can we do? And I know a lot of organizations are looking at, what did they do yesterday that was normal, and all of a sudden today it's not normal? Well, who wouldn't have, a fall? Who wouldn't be disjointed in their normal routine? And we're putting patients all of a sudden at risk just purely by changing away from what they're used to doing. And it goes to all of the things that I said before. So if you're getting in there and understanding what that new normal is, getting good data in, we can have good data out, and we can continue to prevent these things from happening and be able to work with our patients as part of the care team. And again, some patients can't answer these questions, but that's why it's important to, include those family members, those caregivers, maybe it's the neighbors, whoever you feel comfortable with, and being able to pull that information in to our world and use it as assessments. Jen, I'll put you on the spot. Do you have anything else to add?
Yes, I think that one of the things, can we take them off mute? Can we have a little discussion?
Yeah, I'll take them off mute. I'll take you guys off mute as Jen's adding her comments here.
Was anybody at the Fall Symposium for the Iowa Falls Coalition? Can somebody say one thing so I can make sure you guys that we can hear you?
Laura at County Hospital, and there was a handful of us that attended the symposium.
Okay, and who was this again?
Hospital.
Yep,
okay.
we're here.
Yep, okay, thanks.
Very good. I thought that Sue, I can't remember her last name, but I'm also going to ask her to speak on one of these calls because I think she had a lot of really good information about customizing the assessment for the patient. And I don't know if you guys want to chime in if anybody was in on that discussion, but she talked about, when you are doing the root cause, do you really go back and find out, like the patient that comes in and has been falling at home, do we look back and say, is he falling because he's losing his balance, or did it go, and I don't know if you guys remember this, but it went all the way back to he was depressed and he was drinking because his wife died. So that was the root cause of why he was falling. Does anybody remember that, how she talked about that? The other thing that she said that I thought was really interesting, that kind of goes along with what Sarah's saying, is we can't put everybody in the same box. We can't bring everybody in, do the same interventions, and then wonder why it's not working, because everybody needs a little bit different interventions for different reasons. And obviously it's very interesting to me that normal for the patient. My daughter was just in the hospital twice actually in June. She's fine now. She had her appendix out and then she got an infection. But wow, when we talk about being in the hospital and have something normal, we could not wait to get home, and we're young. We're not set in our ways and we can handle a lot, but she couldn't wait to get home just to be able to sleep in her own bed and go to the bathroom in her own bathroom and not measure her pee and not do all the things, have someone walk her to the bathroom or worry about tripping over the IV or the little cap that was on the floor because it was dropped. So I think that these things that we're talking about today are really important. And just to give Sarah a little update since she wasn't there, does anybody else have anything else to add from that symposium? And I think it's really good, not just for Sarah, but other people that weren't present. I know when the Hen Hub, the new platform, gets us, I am going to start a little discussion on what we learned at that, and I'm really hoping and that you guys all start jumping in and saying what you heard, because there's a lot more to falls that we learned at that symposium. So just opening it up, does anybody else have anything else to add from that symposium that they learned?
This is Howard from Boone County. I think one of the issues that she brought out was the place that the patient falls in relationship to the bed in the bathroom. If they get up out of bed and they fall in fairly quickly, it's an orthostatic issue. If they walk 5 or 10 feet, it's probably a balance issue. If they walk over 15 feet, it's probably a strength issue. And so being able to understand in that analysis, the root cause analysis of the fall, of where were they laying when they were found, goes back to the PTOT assessment and strengthening and involving them in those processes, or looking at medications if it's an orthostatic issue.
Howard, I thought that was really good too. I wrote that down, and that's one of the things I was going to post on the Hen Hub. Are you on the Hen Hub?
Yes.
Okay. When I start to post about that, will you bring that up?
Okay.
Okay, awesome. Does anybody else have anything?
This is Laura from Boone County Hospital. What I found very interesting and took away was the sleep pattern and the discussion about sleep deprivation versus sleep fragmentation and how that affects sleep patterns at night and patients waking. So I found that very interesting, and also the effects of lighting, the warm lighting versus cool lighting, and what strategies they put in place in the nursing homes in Minnesota to help patients sleep during the night so they get a good night's sleep, but also their lighting and what they've changed with that.
I learned a lot about that too. I did not realize that one tiny area in the brain really woke the body up or kept it asleep with the serotonin and the melatonin levels. Does anybody, just out of curiosity, does anybody use the red lighting at night in their hospitals? I wonder what that would do. How about, would someone like to comment on the alarms that she talked about?
That was a little disconcerting. This is Boone again. Her recommendation is that, and others in the room, was that we eliminate all alarms.
Yeah, and Howard, I hear you, and I get the concern. And I went to as a rehab professional, this is Sarah again, you guys, I went to a falls study a long time ago, and they did talk about alarms. I know we're dependent on them, and I think there's difference. IV alarms, those kind of things, those are alarms. I think sometimes when we talk about the bed alarms, specifically to the bed alarms, and you guys all know this, all that a bed alarm does is tell you that a fall occurred. Only thing it does is tell you post-event that something happened. The patient got out of bed when they weren't supposed to be, and more than likely, if you're putting an alarm on them, they're probably already down. And so it's a very lagging measure, and I'm not saying that I have a solution for any leading measure other than the alarm, so I'm coming with a problem without a solution, but and we all know, I think many of us have probably gone away from the added alarms, bed alarms, those chair alarms, those kind of things. They're, restraints, and DIA gets all into them. There's a whole calamity of reasons why. But, if we can eliminate or reduce as much as we can, that would be my suggestion. But I am too concerned about how do we alarm, have IVs work properly and yet alarm us when they're, if they're not working or if something's kinked or if they're empty. I don't know, is there any manufacturings out there that have it via Bluetooth so it doesn't ring in the room, it rings at the nurse's station instead, or rings on the nurse's hip? That would be ideal, because the patient doesn't know what it's doing, but it's the nurses that need to have that alarm. I don't know of any IVs that do that.
one thing that Sue did say is she said, what happens when you set your alarm when you're cooking something? What does that alarm or the clock setting allow you to do? It allows you to forget that you need to go back and check what you're cooking. So alarms in that sense, I think that makes a lot of sense, that when an alarm is set, that allows you to forget about what you're supposed to be checking because the alarm is going to alarm you when it needs to. So that's something, as a nurse, I think that's true. We don't pay attention until the alarm goes off, and is that really what we've turned to with alarms? I think that's human nature. I think that's ingrained in us, and I think that needs a change. Okay, we're going to give it up just for a second. We'll come back if anybody has any other comments, but we're going to let Sarah continue.
Okay, so I'm going to mute you guys all right now just so you can be comfortable in your offices, and that way you we've got you all muted and you can go through your normal routine. So let me make sure I got everybody. Okay, there we go. All right, so let's moving on with some of the other activities. One of the things that I mentioned earlier, and Howard, I'm glad that you brought it up. I know you're on mute, but again, a big passion of mine, involving that team before and after the fall has occurred. So when we do a root cause analysis or when we do an assessment, let's start off with assessment, that activity before, are we involving these individuals? And this is not the only people I want you guys to involve, but again, kind of my background from that rehab professional, I wanted you guys to remember those rehab professionals. And I think it's important, I listed here, again, you guys know this stuff as individuals working with this, but does the whole entire team know what's the specialty of the physical therapist? What's the specialty of an occupational therapist? And even remember those speech therapists. So I'm going to go to bat here for a speech therapist. Know that they are experts in your organization. Think outside the box a little bit. We all know physical therapy, ambulation, endurance, balance, strength. Occupational therapy, a little bit more well-known, ADLs, balance, strength, home safety, med management, cognitive, those kind of things. But think about involving your speech therapist. You know, is there a mental cognitive issue? Is there a communication need? So does that patient need to have a way to communicate with the nurses for pain or for the bathroom or those kind of things that they feel comfortable in and with? Do they understand those questions when the nurses do their hourly rounding of, you know, do you need to go to the restroom? Do you need anything? Are you thirsty? Are you hungry? If the patient doesn't understand those questions, maybe it's because of medication confusion, maybe it's because of dementia, lots of different reasons. Your nurses are working hard, your staff are working hard, but if there's a disconnect between the staff saying it and the patient getting it and receiving it, whether it's because of communication or cognitive, then you're working hard without a value. So you wouldn't think of involving a speech therapist with a fall prevention, but there's so many reasons why you'd want to get them included in that. Also think about nutrition and their swallowing needs. Speech therapists and some occupational therapists, but mostly speech therapists, are experts at are they getting enough nutrition into their body so they do have the strength and the endurance, and the meds aren't affecting them, so you lose your blood pressure at different points in time when they move around. If you don't have that person kind of fully assessed or that ability to fully assess those pieces, you're missing key pieces with that patient, and it could potentially lead to a fall. Same way with after, you know, if we think about what happens after the event, involve these professionals and other professionals to talk about, you know, what was happening, what was going on, you know, what did the patient feel, what did they say, are they embarrassed? And I will put it out there for you guys, if you guys have ever fallen in public, walking down the street, not paying attention, tripped over a curb, thought the curb was there, whatever, and gone down, what's the first thing you do other than jump up as fast as you possibly can?
Look to see who's watching.
Yeah, you look to see who's around you, and you're like, okay, did anybody see me? Do I, you know, what do I look like? And that's, the patients do the same thing, but yet we're expected for them to not have this natural reaction of embarrassment. So sometimes it's okay to bring in other people and bring in these other individuals and, you know, have the discussion with the patients. You know, sometimes they're not embarrassed. They don't want to get the staff member in trouble. They don't want to get, you know, those individuals that were caring for them in trouble. And so bringing these other individuals in who are experts in picking up on the subtle clues of what went wrong. So we have to think about kind of assessing the issue as a whole. So I won't spend a lot of time on involving the team, but just know that we absolutely need to involve the team when the patient is in the facility. Also going home, we also think about moving into some of the other work that we do. When a patient goes home, again, these are experts of what's gonna or what could potentially be a concern when the patient goes home, so after discharge. We all know that the #1 reason why a patient is readmitted is some sort of follow-through or some sort of opportunity that they were, you know, we instructed them to do and they didn't do once they got home, whether it's meds or home safety or, you know, or just, you know, doing exercises or those opportunities that we thought we gave them great instructions, but it didn't make it all the way home or make it all the way to the facility. And that person has an issue and then ends up back in our, as a readmission. So again, involving those individuals. One of the things, and I know there's a few larger facilities on the call, but one of the things with our critical access hospitals and other facilities that we have an advantage of, as an OT, I did a patient assessment when the patient came in. As an OT, I was that same OT that was contracted with the home health agency, so I went out to the home, or I was that same OT that was going out to the nursing home, or I was the same OT that was seeing him as an outpatient. And so we have the advantage of this automatic care transition by using our rehab professionals, because often they're the ones that see the patient in every stage as they transition through our services. So please don't forget those care teams, including your rehab professionals. So I'll move forward and get off my soapbox, but if anybody wants to have a conversation about the benefits of a rehab professional, I'm more than happy to have that conversation. So, all right.
Sarah, just a second.
Yep, go ahead.
What do you feel about that person leading your falls prevention, the OT or the PT?
I think it's great. I think they, you know, we all have a lot to do. So how do you engage those other professions within our organization to overcome some of these critical issues for your organization? You know, I'm all about it. I'm all about rehab professionals leading their expertise in falls. You know, and I've always been one. There's organizations that turn over their infection control to their environmental services. I'm all for that as well too. So engaging those individuals. As quality professionals, you guys have enough on your plate. You cannot lead absolutely everything. And so I think it's great to spread it around. You know, have those individuals feel like they're part and they have a mission, they have a buy-in, and they come with a different set of skills that I don't claim to be a nurse. Don't ever ask me to put an IV into somebody. Not going to do it, not going to know how to do it, don't want to do it. But as a rehab professional, I do know how to assess their balance, their ability to transfer, their ability to, you know, be at home safely, and that's my expertise. So tap into that. Moving on to one of the other things that we can kind of think about redesigning and doing differently within our organization is the fall huddle, or just even huddles in general. I know one of Jennifer's ahas that she had at the symposium as well was gathering that information from this is now post-fall, obviously, but thinking of that fall as a crime scene. So when do you gather the information? And we have to think about doing it as soon as possible and not disturbing, and that often means even the patient, from that potential scene. So I want to caveat, of course you're going to make your patient safe and make sure there's no injuries and do your assessment, but a lot of times what we do is we help the patient up, we do the assessment, and then we put him back in bed, and then the nurse goes on, finishes what he or she was doing, and we come back either 5 minutes, 10 minutes, 20 minutes, 2 hours the next day, and then we are expected to gather the data that was presented at that potential scene. So if we think of these as a crime scene, and this is probably a bad analogy in the case of what has happened for the last 2 weeks, but when we have something that happens that's negative, we should cordon it off. We should think about how do we leave as much evidence there as potentially possible and gather information as soon as possible. So, you know, before you move the wheelchair, before you move the walker, before you do those things, what can you do to gather the information? My recommendation is if you have a camera or something, obviously you're not going to take pictures of the patient, but you may need to, but think about privacy and security. But if you can't leave the scene as undisturbed as possible, can you take a photo of it? You know, where was the wheelchair in relation to the toilet? What happened? Again, you know, and Howard, you brought up, what did it happen at the bedside? Was there, you know, a gate belt? Did it happen across the room, 5 feet away from the bed? What was going on? Did we have the right things in place? And so we want to gather as much information around that fall as possible. Where did it happen? What was the environment? Carpet, the tile, was it cement? You know, was it in our parking lot? This is not just patients, it can be family members as well. So what, you know, where and what was in the environment? When did it happen? Was it in the morning? Was it, you know, in the afternoon? Was it in the evening? Did it have, you know, was it at the time of shift change? Was it at the time of meals? So when did it happen? What was happening? Were they trying to do bathrooms, transfers, you know, meals, family members? Family members come in and try to do a lot of things with their loved ones because they think it will help. And we often don't have the luxury of, you know, telling every family member to not do that, but they try to help. I know, even as a very personal example, my mother-in-law had some surgery, and, you know, because she was having pain and her blood pressure was dropping and a lot of other things, they assessed her to be a fall risk. Well, that was great. But then my husband, you know, the well-meaning son, big burly guy, came in and tried to help his mom move from the bed to the chair. And I walked in as it was happening, about freaked out as a healthcare professional, but he was meaning well. I mean, he was trying to do the things that he thought would make his mom comfortable. And then other things, how far did they go? Who was in the room? Who found them? When was the last check? The point with all these things, when we think about doing all these in a fall huddle, is we need to gather this information systematically and repeatedly, because what you're trying to do is not only put together a case for that one particular fall, but we want to see falls over time. So when you start to put these stories together, it starts to give you a picture of what is going on and what, you know, what's the history? What's the run chart look like? You know, so you're starting to put the stories together and act like an investigator to be able to say, how can we prevent these falls from happening? So yes, it's about that one individual fall, but it's also about falls over time, that you can start to link some of these things together. So with that, I just wanted to give you guys an idea of trying to leave that scene intact as much as possible. Obviously, you're going to make sure things are safe and secure and people are as comfortable as they can be, but sometimes that means asking a few questions with the patient sitting on the floor, and that seems kind of adverse to what we've been asked to do, which is take care of that patient, but that's going to be the best amount of information and the most accurate information that we can gather. So, questions on I'm going to unmute you guys, and if you have any questions about the fall huddle, go ahead and let's talk about it. Anybody have anything to add?
How many people on the call include the patient in the fall huddle? Or post-fall huddle, I'm sorry.
This is Teresa from Mercy Sioux City, and we have a post-fall huddle team, and we involve the patient each time when possible.
Good. Do you include not only the patient, but maybe a family, someone, if you can, from there, and you say, okay, this happened going to the bathroom, and they say, well, yes, because they use a commode at home and it's right next to their bed. Do you ever get that information from family members as well?
Well, if they're there at the time, then we would definitely involve them as well, but that's not always the case that someone's there.
Very true, very true.
Or more so, do you follow up with the caregiver or the family just to kind of, inform them this is what we found? Do you tell them about the crime scene or the fall area, what exactly happened, maybe to get some insight?
Well, the primary nurse or someone notifies the family and then the caregiver and the provider. That's not something that we generally do on our part, though, as far as notifying the family, as far as our team approach.
Is anybody else implementing getting the patient involved with the fall huddle, or does anybody else, they hadn't thought about it, but they're thinking about it? Is anybody kind of in that area?
Well, if not, I think I know that we are in a situation where we're really concerned about legal and sharing and being transparent. And I'll just put it out there for us that it's often really intimidating to think about involving a patient, and then you start adding in the family members into that and kind of admitting something you shouldn't do. And so I think it's important to, when you think about a fall huddle, to stick to the facts. Where did it happen? What, think about who, what, where, when, and how. So if you can stick to those things without getting into blame, or we didn't do what we were supposed to do, or those things that can get you into a sticky situation. If you stick to the facts, I think you'll feel more comfortable, or if your huddles go to those facts, you'll feel more comfortable with including that patient, and particularly family members if they're available and around, or caregivers. So, good point. Does anybody have anything else to add? Otherwise, we'll put you back on mute and. Okay, I'm gonna. I think we got you back on mute, so I'll keep moving along a little bit. And one of the last things that I wanted to touch on as we start to think about doing more fall huddles and root cause analysis, I want to give you a new twist on the whys. And I call this, and some of you have heard this, but I call it the 5 whats. So when you think about trying to do a fall huddle and we want to include the 5 whys, I would highly recommend that you substitute the word why instead of saying, why did this happen? Why did this fall occur? Stick the word what in there instead, because what that does is it removes the defensive nature of the question. If you guys think about this, and role-playing with Jen here, as I'll look at her face and I say it, it's like, why did the patient fall? If somebody would say that to me, I'd be like, dude, I don't know. I would be like, I'm sorry.
I was in the bathroom.
I was in the bathroom. I was trying to eat my, my granola bar at warp speed so I could get back to, passing meds. All of a sudden it's a blame game. It's, because what do we say to our young children? It's like, they finger paint all over the wall, and the first thing that comes out of our mouth is, why did you do that? And we get so reactive. So if we would ask the question of what was happening or what was going on at the time of a fall, now you start to stick to a fact-based question of what was occurring instead of why did this occur? It was what was occurring. Because you know what happened, so something was occurring. It's not whether something was or was not occurring. We know something was happening. So what was going on? And then you go through the layers. Instead of asking the 5 whats or 5 whys, you ask the 5 whats. And it really creates a more dialogue situation. It allows individuals to feel much more comfortable, still do all the benefits of the 5 whys, but it allows us to get into that more relaxed situation where we're getting information and allowing the individuals in the room to feel comfortable.
It does sound like a lot more empathetic and a lot more caring to the word what instead of why.
Yes, absolutely. And if you think about asking the patient, why did you get out of bed? Well, I mean, if you say to them, what was going on that prompted you to get out of bed or made you want to get out of bed, they'll probably say, I needed to go to the bathroom. I wanted to get into the chair. I heard a noise in the hallway and I wanted to know what it was. I said that. Instead of saying, why did you get out of bed? What was going on that prompted you to get out of bed? 2 completely different conversations, 2 completely different questions. And not only with the patients, but I think it reduces that defensiveness of our staff as well. And so a little twist on the tool still gets into those layers, still think about going through the 5 layers and doing it repetitively and kind of working your way down into a root cause analysis. So try the 5 whats instead of the 5 whys the next time you do a root cause analysis, or even when you're in any process improvement and you're working on things. I think you'll find that it goes much smoother and it's not as difficult as a facilitator or as a person that's asking those questions as kind of shaking your finger at somebody and saying, why did you have this happen? And so I leave you with that words of wisdom, as I've done probably close to hundreds or thousands of these, is that you got to work into the what's instead. So now is our opportunity to start thinking differently in our work and practice some of these things, be able to take a piece of advice here and there and kind of think about your falls differently, and you can unmute if you can get over there, and do things differently. Sorry, Jen, we're trying to communicate via hand signals here in the office. I shouldn't do it. So now is your chance to think differently in your organization. So we're going to unmute you. You got to try it again because it tells you that somebody left. We have about a couple minutes left for any sort of questions or comments. And if you guys need anything or need any sort of assistance, my information, you always get a hold of Jennifer and she can get a hold of you, but there's my information as well.
As we move forward with the falls prevention community practice, would anybody be interested in maybe going through some case studies for our next call? Would that be helpful?
It's always hard to share. I know you guys, it's hard.
Any other suggestions for what you'd like to hear on the next falls prevention community of practice? Would you like to hear what other hospitals are doing? I know that I am going to ask Sue to come on our call and talk. But if you have any other ideas, if you don't want to say now or if you just kind of want to think about it, please let me know. You can email me or call me. But this community practice is for you guys to improve and to give safer care to your patients. So thank you, everybody, for joining. I want to thank Sarah because I know that she took time out to prepare this and to share this information with us, and it's very valuable. Does anybody have any other comments before we end this call?
All right, you guys, it's 12:30. I appreciate your time. Again, if you need anything, reach out to Jennifer or myself, and I thank you guys for joining us today. We're going to shut the recording off and drop off, and if you guys want to drop off the line, we'll go ahead and allow you to do that.